Thank you, Dr. Buckenmeyer. We have time, about 5 minutes for some questions or comments.
I don't know if I need the other mic. Hi there, Joanne Yanez again. Quick question on the paradigm shift. So you talked about that pain scale, which was fabulous. And I'm curious, having worked with chronic pain patients myself, as well as in education, how do you see the paradigm shift of patient expectations of not expecting the zero?
There we go. I actually don't need this mic, but I understand it's not the thing. The paradigm shift is that pain intensity is still an issue. We often say in the military, pain in life is unavoidable, but suffering is always a choice. And it's educating our patients in the difference between those two concepts. If you've just had your leg blown off or you've just had an operation, you're going to need pain management. And oh, by the way, opioids aren't bad. Dysuvia, for example, that just got approved, a lot of backlash because of what's going on right now. The military was actually desperate for that opioid for a very specific indication out on the battlefield. To answer your question, though, specifically, though, it's helping them understand that that pain intensity is just one component of the biopsychosocial experience of this disease process. And to manage that disease process, they're going to have some personal responsibility, but the things that we're going to be following aren't just that 0 to 10 scale. We're going to want to know, how are you functioning with your interacting with your family? How are you interacting at work? Maybe we've just made a slight movement on your pain, but now you're sleeping so much better that all these other things in your life are getting better. And so that's not a time now to give you more medications. That's now a time to double down on the things that helped with that sleep, the massage and the acupuncture that we prescribed. Is that an example? I think what I'm saying, though, is it's got to be an individualized process and a team approach where all of these disparate silos, I hear a lot of lamenting of silos. And I got to tell you, silos aren't bad. I'm an anesthesiologist. You want my silo in the OR if you're having an operation. I think what we're talking about is we need silos that are bridged with each other and that we're communicating with each other with the patient in the center. So that would be my answer to your question. Let's keep the silos, let's connect all those silos, and then have the patient in the center of that activity.
Thank you. Dr. Benakhtar? Oh, I'm sorry, Dr. Janelle and then Dr. Benakhtar, please.
On? Oh, there we go. I just wanted to dovetail on that. One thing that we use at Stanford is we actually have the choir output, so patients complete this multidimensional characterization of their person at baseline and at each point of care, and so that we're able to quantify their symptoms and their profile, and then use that as a tool to start a discussion with the patient about which symptoms are most impactful, trends over time. It's not a hard sell to engage people in different dimensions of treatment once they understand how it's related. And so that's one way. I mean, we actually have a very frank discussion wherein we use their own data as the tool to engage them in a broader focus on pain management.
Dr. Benakhtar and then Dr. Sherman.
I just wanted to mention, I think it goes back to how we publish the data as well. So as we're beginning to use these questionnaires, it's important to make sure that as we're reporting it and trying to get it published, that we don't just go back to the pain scale. And I would point to an article Dr. Shirk and Dr. Sherman had a few years ago on anticipated effects in acupuncture trials. And they had to go backwards and say, okay, yes, there was some pain benefit, but really there was changes in hope, mood, sleep, fatigue, which often is the soft stuff that is maybe not going to get your paper published. But I think more and more so, if we de-emphasize just intensity being the only marker that we're going to really worry about, I think patients will also get used to that as well. So I think it's a contribution from multiple sources, including research.
Thank you, Rob. Karen.
So these were very fascinating presentations, but there's something that Tripp said that I think we really need to move forward with and talk about a little more, and that's making those bridges and connections and trying to figure out what are the principles of those. That's the toughest thing in the world when we have all these therapies that work for some people, and honestly, we generally can't predict who they work for, so I would love it if somebody wants to take a stab at that.
Dr. Goldberg? Or?
You want to start?
Well, I think that the point, because we have a very similar program to choir, where it's not the soft stuff, I think we need to stop saying that and recognize that that's actually the point, is that's what's meaningful to the patients. We haven't given the patients permission to believe that. And so I think it's critical that the things that we're measuring are what they're going to respond to as far as these therapies. And so I'm an acupuncturist in Maryland. I actually work for my wife, who's a massage therapist. We combine those two it's a boutique service, I admit, because I can't do this in the DoD, and I do it for fun. And I make just enough money to cover my insurance. And we have incredible results, and I don't write prescriptions. And so I'm doing that with these tools because I've changed in my little patient base what we're measuring as success, because they're coming to me complaining of things like sleep and anxiety. Pain is an undertone of those issues, and we all know in this room that the small stuff is actually the big stuff that's contributing to this thing we call pain that we're trying to understand. And so if we help our patients understand that through what we're measuring and then use that in their pathway to better health, integrative health, then you can't help but combine these silos, because it assumes that these groups are working together with this data, and the patient population has already been mentioned is going to come along willingly, because we're going to be dealing with what they want.
Thank you. Doctor?
Yeah, just a quick comment, because I've been enjoying the discussion and
Introduce
the
yourself
overflow.
and institution again, Steve.
Oh, sorry. Steve George, Duke University. The measurement thing is key, and I think, when I heard an earlier comment about the expectation is 0 out of 10, if you measure it, it's actually not 0 out of 10. There's large variability in what people's expectations are. And we have some experience, and it was actually validated in the VA with a crude measure of expectation that distinguished between what they desire, what is expected, and what is successful. And there are different levels for each of those. And that simple tool allows for a more nuanced discussion of what you all are talking about. But I did want to let folks know, it's kind of what Dennis was saying. The expectations aren't the problems. Now, what is desired is very low. But if you can get people to distinguish between expectations and what they desire, which this tool suggests they can, most people are driving towards a very reasonable expectation, and it's the lack of the treatment effect that is an issue. So I just wanted to mention that.
Thank you. Dr. Kearns, last comment, and then we need to switch panels.
Looks like Dan has a...
Oh, Dan, please.
Real quick, just for historical accuracy, when the guidelines came out from the old predecessor to AHRQ about pain control, the goal was stated as less than 4, because there was precisely this debate. There were well-informed people and doctrinaire people. Some said it should be 0, and the people who were clinicians, as myself, said that will just incur an awful lot of side effects and complications. So historically, it never was 0, at least in the federal guideline.
So my comment is really, so Bob Kearns, Yale and VA, my comment is really picking up on Dan's theme, and that's been reinforced for me by the recent MMWR. I'm a psychologist, but I'm starting to sound like a sociologist or somebody paying attention to social context. I think, missing from the discussion really are the key issues of social determinants: poverty, lack of education, lack of insurance, lack of access to care. I'd like to see us bring that back into the discussion as we talk about policy implications.
Thank you. Penny, would you like the last word, please?
Oh, yeah, thank you. Thank you. A couple of things. When he talked about poverty and all that, we also have a tool. It's the pain log, and it's all graphical, and it measures the pain score, but it also measures things like activity, sleep, the fear of the pain, taking medications prescribed, side effects, constipation, sexual activity, their appetite, their mood. We also worry about finances, their smoking, their alcohol use, but it's over time. So they can track this over a long period of time, and so you can begin to see what is happening 3 months ago, 6 months ago, and it also helps them to see that it's not necessarily the pain, it's other things that are contributing to that pain score. But also, a lot of it is, when we talked about patient education, I mean, having them understand that they have to listen to their body and they have to pace. I mean, patient education is what I've been doing for the last 38 years, and it's teaching them all those skills, but everyone's different. And so you have to look, I think the last word is that look at each individual as an individual with a unique set, and no one wants to live in pain. We want our lives back. That's what I hear on every phone call we answer. So just know that we're looking for help. We're not looking for more drugs.
Thank you. Let's give the entire panel a round of applause. Thank you very much.